I'm Jennifer Edgeworth. I am the presiding judge of the 219th District Court in Collin County. I have felony jurisdiction in addition to family and civil, but I also preside over Collin County's adult mental health court with Judge Lance Baxter. And first and foremost, I just want to thank you all for what you do. You are in every way a first responder, and when it comes to mental health, you are so important for capturing all of the information that you see when you get there. And that's why we are so happy and thankful to introduce the EDO, the Emergency Detention Order, that has more information on it. Now you may be thinking, hooray, more paperwork, just what I always wanted. And yeah, it is. But from a judge's perspective, what I can tell you is just like a PC affidavit, this follows that defendant in every way. And so the more information that we can get when we first see the defendant, not just us, but the prosecutors, the defense lawyers, if we can see that there is a mental health issue, it can really impact the future of that defendant in the criminal justice system.
I'm Dave Jan, the presiding judge of Denton County Probate Court Number 1. I have probate jurisdiction, guardianship, involuntary civil commitment jurisdiction, and eminent domain. Presiding over the involuntary commitment court for Denton County, we have about 1,500 involuntary commitments a year. You as the first responder are also the first treatment provider on these emergency detentions for civil involuntary commitment. You're the individual that can provide us with the information we need to identify supports and services to transition someone from crisis care into outpatient care and sustained treatment to try and stop the cycle where they go hospital or jail repetitively throughout the year and your number of calls that you have and respond to them. The information that you provide in the new emergency detention form is that first baseline for us. It provides the who they are, who made the report, who their potential supports and services are, their history, if they're able to provide it, with suicidal ideation, prior treatments, prior hospital admission, previous diagnoses. All that assists us and our treatment providers at our local mental health authority in establishing a baseline of where this individual is at. That is critical to our needs as we start the process of their treatment and trying to change their cycle of life to allow them to be more productive in society and have a more stable environment and to have a more stable future that reduces the instances of law enforcement and hospital contact.
My name is Commissioner Eric Smith with the Texas Judicial Commission on Mental Health, and I am someone who has been through psychosis and anosognosia, which has accompanied that. It's essentially the inability to perceive illness, the inability to perceive psychosis, mental illness, due to the nature of the illness itself, not denial. Those two things are qualitatively different, and it is important to understand that. Denial is a matter of willingness or unwillingness to entertain an idea. Anosognosia is a matter of ability and disability. So if we are looking at someone experiencing psychosis and we don't understand they are not in a position to be able to engage in rational thought and make decisions on their own, what's happening is there is an inability to perceive illness, and thus very unlikely to engage, to seek out or engage in treatment, and that was also true for my story. Now, you may be asking yourself, well, if someone's not able to perceive reality, what are we going to do to help them? How can we help them? And really, it's a team approach.
Hey, my name is Mark Amber. I'm an emergency physician. I've practiced in the Collin County area for over 20 years. Practice at community emergency departments, but also at high-level trauma centers. And really, my favorite thing about my career is I've been able to work with first responders for the last 20 years. 20 years of experience tells me we are a team. Police, fire, EMS, emergency nurses, emergency doctors, we have to work together. What we have in common is we typically have a patient having a psychiatric emergency. We have to determine what's the underlying cause, and often they don't want to come get care. You know, that apprehension by police officer without warrant, or APOW, is just a critical document for the emergency department because it tells that history from the scene in the eyes of the officer. And the more descriptive you can be in the area that you get to tell us what happened and help kind of underscore your decision making about applying the APOW, I just want you to know, as a practicing ER doc, it helps us a lot. That's documentation that I put into my note. That's documentation that if it's the behavioral health assessor, if it's the judge, that they're reviewing your words because you were the one on scene. And it's a document that follows the patient through the continuum of care.
Hi, I'm Sherry George, Director of Clinical Services here at Medical City McKinney. We are so proud to have been serving our mental health population here for the past 2 decades. We have strong partnerships in the community with our local law enforcement, court systems, and our local mental health authority. That emergency detention order, or APOW, is the first link to the intervention that we need to make a successful involuntary commitment. It is really important for us to work together, to continue this collaboration so that we can get the information we need to make sure patients are getting the right care and that they're no longer a danger to the community.
You know, we should talk a little bit more about our mental health patients, and with the new APOW form, you know, what that says and how we interpret that. And let's talk about how patients can deteriorate too on scene with our police officers and firefighters and in the ER. What we're worried about collectively is if our patient presents a substantial risk of harm to themselves or to others. And sometimes we'll be called to a house because the family feels they're at a risk. I had that very patient last week with the fire department and police department that I work with. The patient wasn't overtly saying that they were going to kill themselves, but their actions and their mannerisms made their family feel like they were very much at risk of harm with their loved one at home who had a known diagnosis of schizophrenia, was off their medications, and was moving in kind of a menacing manner around the house. And so it's so important to not just get statements from the patient, because they may be talking to people that aren't there, but also talk to the family members about what they've seen and what they feel. I really try and train all our firefighters to try and call family if they weren't present, if there's family in another state who called out of concern, to try and get a hold of them and get their statements. That substantial risk is not just, in my opinion, the patient voicing suicidality or homicidality. It is context of what the scene looks like. And I have a few examples, again, just from recent cases in the last few weeks. The funny thread here is they all involve people who decided to take their clothes off. But one of them was a patient who was walking down the street with their clothes off, talking to people that weren't there, and walking across the street in some degree of traffic. The patient wasn't voicing that they were going to kill themselves, but their actions in our eyes, as I was involved with a call from scene, were that they presented a substantial risk of harm to themselves by walking through traffic and not really understanding, what they were doing because they were busy talking to voices. Another recent call about substantial risk. So a lady in a car asked a person walking by to call 911, and when police and fire arrived, she was covered in a sheet in her own car, and she'd been outside for hours in the heat. And she said she was outside of her apartment because she was concerned because the voices were talking to her through the walls and things were watching her. And I was involved in that call because the firefighters and police officers asked me, my thoughts as to whether she was a risk to herself. And my judgment is this young lady had no idea and no concern for herself sitting in a baking car in the hot Texas August weather. And so while she didn't voice homicidality or suicidality, she'd had no insight into what was going on. She didn't understand the risk of heat stroke, heat exhaustion, or exposure. And so we collectively decided that an APOW was appropriate on that patient. The challenge of what we do is that, again, this wasn't taught in police academy or fire academy, but what we're asking you to do is articulate on paper okay, I've got a patient who is not alert and oriented to person, place, time, and situation, so they're not really showing decision-making capacity. Now, capacity is one of the hardest things. You know, do they understand the situation? Do they understand the risks of the situation? You know, sir, do you understand that you're walking naked in the street right now and that you're walking through cars? No, I didn't realize that. Okay, then they don't really have decision-making capacity. And then documenting that this patient's not expressing capacity, that they don't have self-awareness that they've been walking through traffic, that they don't have self-awareness that they're sitting in a car and it's 104 degrees outside and they've been sitting in the car sweating for a few hours, that they can't articulate back to me as a police officer or firefighter what the risk is of sitting in your car and baking in the heat. That person doesn't have decision-making capacity and doesn't have their own best interest at heart. And that's where I feel they need help. And an apprehension by police officer without warrant brings them to the ER, brings that documentation of what happened on scene, what we saw, that then carries through to the mental health assessment and hopefully to the inpatient psychiatric hospitalization for the patient. So really what we're doing as part of the emergency care team, as a first responding police officer, we're connecting the dots with the mental health crisis to the risk of harm to the patient. I arrived on scene to a patient who's in a car, has been in there for hours, it's 105 degrees outside. They have not displayed decision-making capacity. They don't understand the risks of hyperthermia and heat stroke. And they cannot connect their mental health crisis and protect themselves from the pending heat stroke by sitting in a car. And we have to be able to document that and say, this patient lacks capacity, give examples, you know, they're talking to voices, and they cannot express to us what is truly a concern for their own well-being, which is heat stroke, or hypothermia in the wintertime from sitting outside, or walking through traffic. We have to connect that lack of capacity to the risk of what they're doing, to the risk of getting hit by a car, to the risk of heat stroke. And that, to me, is very clear logic about lack of safety and lack of self-care, which then warrants them being seen by me and taken to the emergency department, seen by me in the emergency department, and then probably transferred to a psychiatric hospital. Again, the ED is where we evaluate them for medical stability. I make sure that patient who's been exposed to the heat is medically stable, that patient who walked through traffic doesn't have an electrolyte derangement, and once they're determined to be medically stable, we then transfer them to a psychiatric facility.
So when it comes to deterioration of functioning, as a police officer, you may be out in the community and you come across an individual, maybe at a 7-Eleven, who is, you can tell is behaving bizarrely, but is also just exhibiting symptoms that are of concern. Maybe it's 102 degrees outside, which is not uncommon for us here in Texas in the summer. And they don't have shoes on, and you know the pavement is hot and it's burning. It is 109 degrees. They look like they are maybe responding to external stimuli, like they're speaking to themselves. They are sitting on the curb. They look like they are in distress. You can tell that they look dehydrated. They're asking maybe for water. It's just a piece of the mental illness. The severity of that mental illness is that they don't realize that they are ill. And so it can come across like they're defiant, combative, or just uncooperative. But a part of that major symptom of that illness is that they're not aware of what they need. And them not being aware of their need puts them in great risk of harm to themselves and even possibly someone else.
My name is Jalen Shumpert, and I'm the Director of Business Development for an inpatient psychiatric and residential treatment facility. We definitely understand that an EDO can be cumbersome and can require some extra time on the front side of getting an individual the care that they need. However, it is extremely beneficial to create a proper treatment plan for them and to be able to help get them the care that they need long term, hopefully decrease their repeat hospitalizations that we're going to see from an individual on a regular basis. We're trying to make sure that they're getting the proper care, that they are getting the follow-up care that they need. So every bit of information that you guys can provide on the front end is beneficial to us and will save time on the back end.
Your documentation of exactly what happened on scene, I can't underscore enough, is hugely important to our work up in the ER. So we appreciate the time you invest in getting patients to us to evaluate them and to have the documentation that supports what happened pre-hospital. So if I could ask everybody who I'm so thankful that you're part of our first responder system as police officers, to do the best they can to document on an APAL what's going on with the patient and how their behavior might put them at risk or somebody else at risk. That is the key piece of documentation in patient care through the continuum all the way to the psychiatric facility. We all want the same thing, which is for them to get care.
Hopefully the form provides some guidance for you all as to the information we're looking for. A lot of people spend a lot of time going over it and looking at it to make it as easy as possible, because we know as first responders, your time during the emergency detention process is valuable to you, so you can get back on the street and do your job that's so important to the community. So when you're using this form, please take some time, try to get the best information you can, because it allows us to develop a course of treatment that might assist this person for out to a year or more, depending on the resources available in your community.
Working together and collaborating with the law enforcement and the hospitals is vital, because in the end we want what's best for the individuals, which is to get the most appropriate care and to be able to have a continuity of care.
Together, police, EMS, emergency medicine, we can be successful in getting patients the care they need, which is why we're all here. It's why we all went into this. So thank you for watching this video and working with us.